Today, we are having 3 programs. The first is a case presentation by Dr. Basabendra Chowdhury. He will be presenting a case of complication in a case of a LMC LED stenting. Followed by, there is a talk by Professor Harikrishnan he is a professor at Sri Chitra Institute, Thiruvananthapuram. Plus, we worked together on many occasions. The last, but not the least, is in the National Heart Failure Registry, where he was the chief coordinator and I was a journal coordinator. This got published recently in European Journal of Heart Failure, perhaps. Harikrishnan, am I correct?
ESC heart failure, sir. European Society of Cardiology heart failure. ESC heart failure journal.
So he will be speaking on a discussion on hemodynamic data. And last but not the least is a case presentation by Dr. Bipul. He will be presenting a case of, perhaps you are presenting a case of congenital heart disease.
Yes, sir.
So without wasting any further time, let me request Dr. Basabendra Chowdhury to start his talk.
Good evening, teachers and friends. It's a great privilege to be able to present a case which...
Basha, just a second. I forgot. Dr. V.S. Narayan, he is also present. He has some problem with his teeth, but he will be interrogating the candidates. Please, Basha.
Thank you, sir, for this opportunity to be able to present this case in front of such a respectable and renowned pool of teachers. So I will go to my case. It was a case. It was an angioplasty which was done recently. The patient was a 48-year-old male, ex-smoker with history of dyslipidemia. He had an SES followed by stenting to LAD in 2014. Over the last 2-3 months, however, he was having a refractory effort angina. He was a farmer and he had to do quite a bit of physical activity throughout the day, and he was having significant chest pain, which was gradually progressive over the last 2-3 months, despite maximal doses of drugs on OMT. So his echo revealed that ejection fraction was 45% with apical anteroseptal hypokinesia, and the ECG suggested evidences of old anterior wall MI. So as his symptoms were refractory and gradually progressing, so we decided to go for coronary angiography and see what the status of the coronaries were. So these were the shots of the left system, which revealed that.
Doctor, can you make it a full screen?
Are the videos visible?
Yes, they are visible.
So there was a 80%, at least 80% tight stenosis at the LAD ostium. The stent, the prox to mid LAD stent, was patent. However, it had some disease irregularly throughout its length. The cranial shot revealed that distal to the stent, the artery was narrow caliber throughout. However, there was no focal area of stenosis or any significant lesion which could be addressed. And
please run and show the distal end of the stent again.
Okay.
The distal end of the stent? Okay, it's reasonable. Okay, good.
So the LCX was codominant. It was a good caliber vessel and flowing. The RCA was codominant, a small caliber vessel. The RCA short. So in view of the progressive symptoms, we decided that the LAD lesion had to be addressed. And the issues which came up were, first of all, it was osteal LAD lesion with some amount of ISR, which was visible angiographically. The lesion was maximum just proximal to the stent involving the LAD ostium, and we had to decide whether we could leave the. We had to give another stent because the disease was proximal to the stent. So how to address the ISR component and what to do with the proximal LAD, the osteal lesion. So we decided that we had to give a stent to the covering the ostium of the LAD, and by examining the different views, we saw that maybe we had to bring the stent up to the left main because the angle was not suitable for osteal positioning. And anyhow, we decided to go for a IVAS guided procedure because we wanted to see the extent of the ISR. If we are giving a new stent, where to keep the stent, how much minimum of overlapping we could achieve with the old stent, and to assess the vessel size, the LAD as well as the left main, and if anyhow there was any area, if the angle was conducive so that we could leave the stent at the LAD ostium. However, angiographically, we were quite sure that we had to bring the stent to the left main. So we took a few more shots with the guide cap, which revealed a similar result. Osteal LAD lesion. The cranial shot showed that distal to the stent, the landing zone was fairly healthy. Then we did the IVAS. So the IVAS revealed that, as expected, at the LAD ostium, there was tight stenosis, more than 80% plaque burden. The vessel size was approximately 3 to 3.25 millimeter. At the distal end of the stent, the old stent, so there was a relatively healthy disease-free area from around till the 10 millimeters proximally, starting from the distal edge of the stent, where we could land and where could plan to land the new stent. And the LM was 3.7 to 4 millimeter vessel at various lengths. So we went ahead with wiring of the LAD and the LCX.
Vasu, can you tell us what was your plan, your strategy? So IVAS, what did you find in IVAS, the mechanism of ISR? What was your strategy for angioplasty of this patient?
So our strategy was we were going for a LM to LAD stenting. The ISR, it showed that neointimal proliferation, especially at the mid part of the stent, proximal to mid part, there was evidence of fibrosis. Calcification was not so severe. If I can show this, yeah. So if we look at the middle image, it is showing ISR with the neointimal proliferation, and fibrosis is present. Calcification present at some areas outside the stent, but not a circumferential or not that much significant. And the right one is the distal part of the stent, which is appearing to be relatively disease-free, where we plan to land the new stent. And this is the left panel is showing the ostial LAD. There is no stent. The ostial LAD is showing significant narrowing. It is a mixed fibrofatty plaque with occluding 80% of the lumen, and this was the tightest lesion. He had also some specks of calcium seen, but no significant calcium as such.
So what do you feel? What was the mechanism of ISR? Because stent to me looks around 3 millimeter, which is not a malopposed. The MSA of the existing stent was also good. You mentioned about new intimal proliferation. Generally, the mechanism is more commonly seen in bare metal stents. Or drug-eluting stent is generally new atherosclerosis. So how do you explain why the ISR happens? Because if you do not address that, then again in future there will be another ISR. So you mentioned the stent was deployed 5 years back.
Yeah.
So within 5 years, it was likely a drug-eluting stent. So what was wrong with the patient? Did he continue with all the medicine? And you showed it was
Arindam, may I highlight one thing? It was first done in 2014. That is about 8 years ago, when the patient was about 31, 32 years of age. So there is something going on in the body in terms of atherosclerosis. And perhaps you have to, afterwards, you have to address those issues. Why it is such an early and so aggressive and recurrent atherosclerosis going on, and we have to address whether we are missing some uncommon risk factors as well. So maybe that is underlying somewhere.
Yeah, yes, I fully agree. But Basha, what he mentioned, it is new intimal proliferation. He is not mentioning that it is new atherosclerosis. So I fully agree to you. In fact, if we take it as new atherosclerosis, then our job is simple, because that is how it is more easier way of explanation. So drug-eluting stent, new atherosclerosis after a span of around 8-9 years, which is common. But if it is new intimal proliferation, then we have to think differently. Because the stent, to me, the original stent, the operator did a fair good job. There was no issue with the stent.
Sure.
So anyway, Bashop, tell us the strategy. What did you think? How will you make it, a good outcome? What was your plans? And what are the alternatives you could have thought about it?
So we did not have the records of the which stent was actually used. Since we were planning to stent from LM to LAD, the LCX ostium was relatively disease-free. So we decided to go for a provisional bifurcation stenting. We wanted to keep access to the LCX. We wanted to stent LM to LAD with meeting the size of the LAD vessel, and we tried to choose a stent which could be expanded up to the size of the LMCA. And the distal part, we had thought whether we could have given a drug-eluting balloon. But since we saw that we had to cover, first of all, the drug-eluting balloon could not be afforded by the patient since he was using the health card. So we had to use a stent only, and we also saw that we could leave around to a 15 millimeter, 12 millimeter of stent distally, the old stent, which showed that the apposition was good and there was no disease in that segment. And if later on we saw that the LCX ostium was diseased or it was narrowed after stenting of the LM to LAD, then we had to address and go for a different strategy. Otherwise, we planned LM to LAD stenting, keeping in excess of the LCX provisional.
So what was your thought for pre-dilatation? Any thought about using some special devices or something like that?
So for pre-dilatation, we decided to use a scoring balloon and NC balloon. As there was no calcium as such, so we thought that these two balloons will be helpful and in gaining a significant diameter.
So the decision was fairly simple, wasn't it? The decision was fairly simple, that you take a stent which is, not all the way through the older stent, just halfway, and then stent from the left main, and use a stent which was expandable to say about 5.5. So you were not expecting any kind of, problem with the circumflex, were you?
Not really. Not really, but it was a codominant vessel, so we had to be careful.
Yeah, that I agree. Wiring it is definitely there, but it looked like a very simple case to me, at least. But then things go wrong when you think that it is simple.
So what stent did you choose? I mean, you planned from left main to LED, what size?
So the stents we had at our disposal, so we went for a everolumus eluting stent with a cobalt chromium, platinum chromium platform. So we decided to take a 3 mm stent, which could be post dilated to 4 to 4.5. To 4 definitely, and to up to 4.5 a bit risky, but according to the data it can be done. And the LM size was actually 3.8 to 4 mm according to IVAS. So we thought that if we take a 3 mm stent, and we can then safely dilate, post dilate to a 4 mm, which would meet the size of the LM.
So 3 mm stent, length of the stent, what did you choose?
Length of the stent, we took 28 mm.
No, what? Okay, fine. So you thought how much you keep in left main?
Around in the, we did not want to come up to the ostium, mid shaft maybe. So we wanted to keep adequate length for a pot of the left main. So it was, say, if we take 8 to 10 mm from the ostium of the LED towards the left.
So you had all your hardware
and collaborating with the IVAS, the length came up to be around 28 mm.
Fine. So you had already hardware. I mean, the pot balloon, 6 mm pot balloon, and all those kind of things.
Yeah,
okay, fine. I agree with your strategy. Go ahead, please.
Bishop, keep a watch on keep an eye on the watch as well. You're having another 10 minutes time, please.
So pre-dilatation with the scoring balloon, 3 into 10 mm NC scoring balloon, non-compliant scoring balloon was done from mid LED till the ostium of the LED. And this showed that there was a fair result after the pre-dilatation, after which we took the stent. We confirmed the position of the stent in different views. So actually we had to come a bit more proximally, near about to the left main ostium. Because if we corroborated with the IVAS and the angiography images, so since the left main was healthy and disease free, so we decided not to.
No, but why all the way up to the ostium? You said initially that you had planned to go just about half the shaft. So yes, why would you like to use a long stent right up to the ostium?
Sir, the length we had selected, we thought that the length was adequate. But when we took the shots and in different views, cranial, caudal views, the distal LED, the distal landing zone, which we wanted, where we wanted to keep the distal edge of the stent. So when we fixed that, we saw that the proximal end was coming near the
So it was a longer stent which you took. You could have, had you used a shorter one, then perhaps you would not have to go to
the shorter, sir, the shorter stent was significantly shorter. Then we could have missed the lesion and
the available size made the difference.
So since we did not want to compromise on the stent quality, so we had to take that length only. The stent was inflated at just above the nominal pressure. Then pot was done in the LM with a 4x8 NC balloon. Since we had a good amount of length in the LM, then this was the shot after the pot. Then we decided to post dilate the. Then we recrossed the LCX, and then we decided to post dilate the LED stent. It was done with a 3.25. So the LED was around 3 to 3.25 millimeter vessel according to IVAS. So we took a 3.25 into 12 NC balloon and did the post dilatation. And after this dilatation, actually things got complicated. So after the post dilatation balloon was inflated, deflated from LM distal LM to LED area. After that post dilatation was done from distal LM to LED. So after that, the stent balloon was deflated, but it got deflated according to the fluoro. It was not coming back into the catheter over the wire. So we did not want to force. So we again made sure that it was totally deflated. So we made sure that it was totally deflated. We used other syringes and the inflating devices. It was deflated completely, but it had got stuck to, I think, the stent struts, or there might be some calcium spicules which we did not find during the IVAS. I don't know if, the exact pathology, what happened, but it got stuck. Then as we gradually pulled it back, it was coming after multiple deflations were given. But then we saw that the stent got deformed. So this was the thing that happened. If we look at the left panel, we could see angiographically that stent had elongated proximally, and when we took the stent boost, it was clear that there was significant deformation of the stent. There was some areas of discontinuity. Stent had elongated and moved proximally into the aorta. And luckily for us,
this was a New York balloon or a Knox balloon?
Sir, the LMCA balloon was New York. The LED balloon after which it happened was Ox, unfortunately.
Dr. Narayan, I think there was stent fracture, and the fractured end has caught the balloon.
Yes, that's it.
And when
that's what usually happens.
Out, the whole spiral has got stretched and elongated. The whole anatomy is distorted.
One of the spikes in the stent got caught in the balloon.
Absolutely.
And then when he tried to pull it out, the whole thing.
Absolutely. The whole thing is deformed. Yes.
I don't think it is calcium. It's just that.
Yeah.
It happened.
It's the stent strut.
After the pot, it happened.
Yeah. There was fracture of the stent.
So next, we had to think about what were the options available to us. One good thing was that the ward, we had the access of the ward, and so either we had to, the balloon was now moving, so we could have taken out the balloon.
How was the patient doing?
Yeah.
How was the patient clinically?
Clinically, thankfully, patient was stable up till this time.
Okay.
Because we also took angio shots. The arteries were flowing, and luckily there was no evidence of thrombosis or stenosis or in the arteries. The arteries were flowing. Patient was hemodynamically stable. So either we had to do something using this wire only, this access only, or another option was we had to again take another catheter and do a separate wiring through the struts and make together altogether a new lumen had to be manufactured. And in that case, a significant amount of stent, this deformed stent would have got crushed. Wall of the LM.
That looks like a good strategy, that you flatten the stent in the vessel and then put another one across. But it is not easy. It's easier said than done.
Yeah. So what we decided that we would not use another wire or go to the struts, because we had since we had the access. So what we did is that we took that same balloon inside. It was going, luckily. Okay. So and with that, with the balloon support, we gradually took the catheter towards the left main and see what was happening to the stent. So luckily, as we can see on the right hand panel, it got shortened, and yeah.
Great.
God is kind.
After that, we inflated the balloon to make sure that it gets approached to the wall as much as possible.
And the balloon was not punctured, huh? You used the same balloon. It was not punctured already.
No, the balloon was not punctured.
That's strange. Yeah. Okay.
It got just stuck to the struts. I don't know exactly at which point, but as you rightly pointed out, the whole spiral got pulled proximally. Yeah. So after that, we decided to inflate the balloon.
I think it was not the same balloon. It's another balloon, because it is very risky to reuse the same balloon.
No, but that balloon was not
take it out. It was there.
The balloon was already there, and he was lucky that he was able to push it through that stent over that wire.
No, this is the stent balloon. Bashav, you mentioned this is the stent balloon.
No, this is not a stent balloon. This is the balloon he used to dilate after.
It's a post-dilatation balloon.
The 3.25 into 12 NC balloon.
So that is the thing. It is another balloon. It has to be.
Go ahead, Bashav.
Yeah. So we just inflated to nominal pressures, 8 to 10 millimeters, then deflated, and with the pushing the catheter towards the left main, we took the balloon out.
Got it out.
Yeah. So if this was not possible, then we had to do another wiring and go through the struts.
No, but how did the stent look like after that?
It was looking like this, sir. This right hand image. This is after the dilatation to the nominal pressure.
Show the
flow,
flow,
it is all
please.
right to leave it like this. Yeah, but
no. Then we decided that we had to give another stenting. So it would have been too much risky to keep such a deformed stent like this. And anyhow, since we had to do another part over a deformed stent, then we did not know in what shape that this stent will end up in. So we decided to use another stent. So we decided to use a stent with a better radial strength, less prone to deformation.
Which stent was used initially?
Sir, initially it was a synergy stent, Boston Scientific synergy stent, platinum chromium, everolimus eluting stent. Next, we decided to use Zions Alpine stent. It is a cobalt chromium based everolimus eluting, and also the marker to marker stent, which will help us in better positioning.
Show the final thing, Vasham.
Vasham, did you do a bypass at this stage?
Yeah, since now IVAS we kept it for later. After we had we could
the stent fracture, or what is that?
Because sir, we thought it would be risky because if it was stent fracture, some struts were protruding inside, which actually caught the balloon. Then if the IVAS catheter also gets entangled or
gets I agree. Man. It's better to be safe than sorry. Trying to push in and an IVAS through that deformed stent and another stent, I don't think is a good idea. So I think you did right that not used it.
I think it's a good result at the end.
Yes.
Dr. Narayan, do you think that this patient should go home with an anticoagulant with an antiplatelet?
Possibly, yes, because of the deformity and because of 2 stents sitting in the left main. I mean, you could put him on 2.5 milligram of rivaroxaban in addition to the antiplatelets.
Maybe ticagrelor, yeah.
With aspirin, ticagrelor plus 2.5 BD of rivaroxaban.
Yeah, that's what I think.
Yes.
This was the new stent. We had to keep around 2 to 3 millimeters of stent protruded into the aorta. We had no choice.
Yes.
At this point of time, we could not shorten it to its original length.
End result is good, actually.
Yeah. So after that, we did a pot with the 4 into 8 millimeter balloon, NC balloon, and we made sure with the stent boost images that the morphology the stent looked good enough. And then our patient was stable. We recrossed the LCX, and then we decided to take another IVAS run. It showed that in the proximal LAD, the stent was well apposed. The area achieved was around 9 millimeters square. In the distal LM near the confluence, the LCX ostium looked quite healthy, and we decided to leave it as such. We saw that there was we could go to a higher pressure. There was some more apposition could be attained. So we again we did a report, and with the same 4 millimeter vessel NC balloon, we went up to higher pressures, 20 to 24 atmospheric pressure, and then the final result was this.
Was there any mismatch between the distal stent and the non-stented portion of the LAD?
Sir, actually there was earlier a stent was there with some amount of ISR. So we landed this stent somewhere in the middle of the old stent. So it was already 3 millimeter diameter was attained previously.
So nothing was done with the ISR?
Actually, we could find a spot in the distal part of the stent which was relatively diseased.
Sorry, I have joined late. Maybe I am asking some repetitive questions. Okay.
So this was the final result.
Wonderful result. Very good job. Congratulations.
Sarc looks a bit distorted now. Why is that? It was completely healthy before. Sarc looks a bit unhealthy now.
Sarc.
Just show. See the Sarc. The mid Sarc looks a bit unhealthy, which was not there before. Maybe I have missed.
This view actually, sir, this is a PA view, upfront PA view.
No, even you go back to another view back.
Yeah, I can show you the
just show
normal
this.
caudal
view. Doesn't look nice. Just show this.
This is a bend, sir. There is some lesion, but with the
somehow
bend,
I missed it in the first view. I don't know. Okay.
Good job. Very good job.
Very good job.
Final result was good. I think this guy needs a re-angio after some time. Just you need to check.
Lady Luck was with him.
Yeah. You are lucky as well. So thank you, Bashar. Thank you very much.
Look into the risk factors, the alternative risk factors
so
as
after
well.
that, we checked the lipid profile. So with patient was taking, he is not giving a clear history of what happened in the in-between years. However, for the last 1 year, he is on regular medication. The LDL is 130 with 40 millimeters of atorvastatin. So
that's it.
We added ezetimibe and we asked him to repeat the lipid profile after 6 weeks. Then
how much atorvastatin he was receiving?
40.
40.
You should have gone to 80 straight away.
To 80 at least.
Yeah, because I had given him 80 before the procedure. 1 month back, but he was having body ache and muscle pain. He's a farmer, so I had to bring it down to 40.
Add on bempedoic acid. Maybe
bempedoic acid is another choice.
You have to be very aggressive. Here your LDL target is 30.
This type of a scenario,
your LDL is
should
30
be
here.
as low as possible, not at that range.
What were the bleeding risk? What were the bleeding risks?
Bleeding risk, I don't think he calculated.
Bleeding risk, sir, he was 45-year-old and only BP was on the higher side, but it was fairly controlled with antihypertensive.
So we're wanting to know the Hasbled score.
Yeah. So Hasbled score was at 1.
Okay. So bleeding risk is low.
Okay. We are running short of time now.
I just wanted to ask one question. So should we give anticoagulation to this patient?
Yeah, that's what Dr. Ray was saying. So why not add 2.5 BD of rivaroxaban?
That's why I asked about the bleeding risk.
Yeah.
At least for first 3 months, you do it. When the stent is raw and not endothelized. I think you should do it.
So would it be safe to use ticagrelor, aspirin and rivaroxaban?
Yeah, this Hasbled you say is one, so you can very well use it.
Yes.
But if you are, I think you should use ticagrelor.
You can take, ask him to take a double dose of PPI at least for protection of GI bleed. Other bleed you cannot protect.
Okay, Bashar, thank you very much.
Excellent.
For this nice presentation. Excellent case. So let us go to our next program. Dr. Harikrishnan. Dr. Harikrishnan, please start with your lecture.
Are my slides visible?
Yeah, it's visible, and there are 2 or 3 postdoctoral students, Dr. Bipul, Dr. Arindam, and Dr. Aditi. They will be interacting with you.
Okay, sir. Thank you for the invitation for this presentation. So when the postgraduates are asked to discuss tracings, they have to tell whether it is what is the type of the tracing, whether it is a pullback or simultaneous, what are the type of waveforms. They have to interpret the data. They have to discuss it and then finally reach the diagnosis. Don't jump into the diagnosis and get into problems. So what are the 3 types of waveforms? The 3 types of waveforms are seen in this hemodynamic tracing. The first is the atrial type of waveforms, where there will be 2 waves per cardiac cycle. That is what you are seeing here. Then you have the ventricular type of tracing, where, to put it simple, it can reach it usually touches the baseline. Then the arterial type of tracing, usually it will not touch the baseline, and both ventricular and arterial will have a single waveform per cardiac cycle. This is to make it very, very simple. So you should know, before starting, you should know the very basic, that is systole and diastole. Many times when we ask suddenly what is systole, you make a mistake. So the systole starts from the peak of R wave to the end of the T wave. So that is, you have to be very, very clear about those things. Then I have already discussed what are the 3 types of waveforms. The atrial waveform, where there will be 2 waves per cardiac cycle. The ventricular and the arterial waveform, where there will be single wave per cardiac cycle. ventricular and arterial will be differentiated by when the base, it touches the baseline, most likely it will be a ventricular, but there may be exceptions which we will discuss subsequently. So you should also see the scale. When you are given a tracing, you should see the scale. Sometimes it may be 200, it may be 100, it may be 40, or it may be 20. So always see the scale before jumping into conclusions. And different hemodynamic monitors give different scales like 20, 40, 100, or it can be 25, 50, 200. That can be like that. So it depends on the different machines. So you will be, when you are given a tracing, there will be waveforms and there will be a mean. There will be a straight line which is going across the tracings. So that is the electronic mean which is generated by the machine. That is called electronic average. So the speed of recording also is very, very important. As you see, the speed of recording. This is the usual speed is 25 millimeter per second. We want to for example, calculate the mitral valve variant, we will go at 100 millimeter per second. How to record pressure tracings ideally? These are the questions which usually will be asked. So what is a pressure wave? It's a periodic fluctuation in force per unit area. Most cath lab transducers will have a natural frequency of 60 to 70. Usually the waves are picked up to 120 beats per minute. Beyond that, the accuracy will be very, very minimal. I am not going to the details of what is a Wheatstone bridge and what is a pressure transducer and all. I think you should be knowing those things. We usually use the fluid fill systems in the cath lab. The advantages are they are cheap, disposable, and simple to calibrate. The other type of pressure measurement systems are the solid state systems, where it is not hardly used for pressure measurements, except in the case of an FFR, where it is FFR is a solid state system. So there are some, if you are asked, you can say that the Miller pressure catheter is an example of a solid state system, Miller pressure catheter. This is not routinely used. Then before going to that, you should know what is any pressure measurement is measured based on a reference point. That is a 0. So what is that in a human pressure measurement we use in the cath lab? That is called a phlebostatic axis. That is a fourth intercostal space mid-chest, irrespective of the head elevation. Irrespective of the head elevation, it is the fourth intercostal space mid-chest. That is the phlebostatic axis. So then we should know some of the terms like calibration. Calibration is the zeroing, where you should establish the atmospheric pressure reference as 0. So that is a point where the three-way, you connect the pressure, the connector or the cable to a point in the three-way. The point where the three-way opens to the atmosphere, that is the reference point or 0 point. So once you have adjusted, never lower or raise that particular three-way, because that will change the 0. So you should not do that. Once you have calibrated, should not change the position of the transducer. Then calibration, we know, this is what I said. Once you fix the reference, then don't change. It will affect the calibration. So how to record optimal pressure tracings? Zeroing the transducer, I said, at the level of stopcock, that is a three-way, mid-chest, left intercostal space, that is the phlebostatic axis. Shorter, larger catheter is better. For example, a 7 French will be better than a 4 French catheter, so that the waves will be transmitted accurately. Optimal length of the tubing will be 4 feet. A rigid catheter will be better. Example, a braided, metally braided catheter will be a better, give better pressures. Optimal damping. You have to remove air bubbles, otherwise you must have experience that whenever there is an air bubble, the pressure dampens. And if you have multiple transducers, for example, if you are doing a balloon mitral valvotomy, you have to have 2 pressures. Both transducers should be zeroed at the same level and also should be calibrated against a standard reference. Ideally should be at 3, 25, 50 and 100 millimeters. Ideally you should do that, especially when you are doing a very good hemodynamic study. And always flush the catheter with saline before measuring. That is when there is a fluid with high viscosity, for example, contrast, can damp. So that is always very, very important. And also for example, if you take a patient in the afternoon at 4 o'clock, the patient is fasting from the morning, most likely the RF mean will be very low. And if you are measuring a mitral valve gradient, it may be spuriously low because the volume status is low. So this has to be considered. And always there will be respiratory variations, especially when you measure the pulmonary capillary wedge. So where do you measure it? All the pressure recordings by convention, it should be measured at the end expiration. The end expiratory reading should be the measurement which you have to take. Most of the cath lab machines will have a respiratory monitor also. So how are the usual pressure tracings recorded? So it can be a pullback. So can the students interpret this tracing? Who are there? Students, can you interpret this tracing?
Sir, Bipul and Arindam is there. Sir.
Yeah, please. Bipul, go ahead.
Sir, ventricularization seen with the ectopics. Sir.
Not ventricularization. I have written it is a pullback pressure tracing.
So this is a, sir, this is
written as PA. It is written
so this is a pullback from the pulmonary artery to the RV.
Very good. What does it show? What does it show? Is everything is normal? What is the pulmonary artery pressure?
Sir, here it is around about 70 millimeters.
70 by?
70 by 40.
40.
Yes.
Okay. Is it a normal pressure? PA
No,
pressure?
sir. No, sir. PA pressure is elevated.
Okay. And is there a gradient between PA and that is how you have to interpret? This shows the
yes,
pulmonary pressure tracing. The systolic pressure is around 80. Diastolic pressure is around 40. It is elevated. The pullback from RV, PA to RV. Is there a gradient between PA and RV?
Sir, no, sir. So there is.
Huh? Is there a gradient between PA and RV?
Sir, insignificant.
No, sir, not much.
No gradient.
No gradient. Just
gradient between PA and
ignore
RV.
this type of things. Say there is no gradient. This is okay.
And these are whenever we pull back during the RVOT, we will have some ectopics usually because of the RVOT irritation. Okay, so this is a pulmonary hypertension without any RVOT gradient. So this is a pullback tracing. And can somebody say what is this tracing? What is this first part? First part.
So
what is the first part? No.
Just this is the atrial tracing.
Atrial tracing, and then it goes to what?
Then it goes to RV, then advance into the PA.
Then it goes to a ventricular tracing because it is touching the baseline. Yes, then it goes to a
PA.
Arterial tracing.
Arterial tracing, then pulmonary capillary wedge.
So you can see all the types of tracings, and you can see this is a push-in or the flotation catheter which will float with the blood flow and goes to the pulmonary arterial wedge position. Okay. So these are another type of tracing. So I'm not going to those values. We will discuss it. This is the simultaneous pressure tracing. Can somebody discuss this?
So there is a gradient between the.
No. First discuss what it is. No. There is no gradient. What is it?
So this is a simultaneous tracing of the LV and the aorta.
Okay.
And there is a gradient of around 60 millimeters between the LV and the aorta, so likely an obstructive lesion, likely aortic stent.
Where?
At the likely at the aortic stenosis, likely at the valvular.
Well, that we will discuss subsequently why it is valvular. Let us. So there is a gradient at the LVOT.
Yes, sir.
What type of gradient we will discuss subsequently. So there is a gradient at the left ventricular outflow tract of around 60 millimeters. Okay. Yeah. Now we'll go to some atrial waves. How will you identify the atrial waves? So the P wave will correspond to immediately after the P wave, we will have the what wave?
The A wave, sir.
A wave. Okay. Then we will have when there's a
corresponding to
the Q wave. QRS, what will
we have
have?
the C wave and the V wave following the T wave.
T wave. So these are the waves in the arterial tracing, right atrial tracing, for example. And you have the descents also, X and Y descents. So this is the difference between a right atrial and left atrial pressures. What are the differences usually? Right atrium, which wave will be more?
So the LA pressures.
Right atrium among A and B waves, which will be more usually?
The A wave.
Yeah, in ventricular and LA pressures?
The LA pressures, likely the V wave, sir.
V wave will be likely to be more. So LA versus RA. So the LA, A and B are usually larger. Why the LA waves are slightly larger or the LA pressure is slightly more than the RA pressure? Because of the lower compliance.
No.
Why the left atrium has a lower compliance? Many reasons.
So,
it is relatively thicker compared to right atrium. Also, the right atrial, left atrium is decompressed by the relatively stiff things. What are the two things? The pulmonary veins and ventricle. Left ventricle is thicker. Pulmonary veins are thicker compared to IVC and SVC and also the right ventricle. So these are the reasons why the left atrial pressure is slightly more than the RA, and also the V wave is slightly more because V wave indicates what? Compliance. Okay. So these are the things you have to discuss. So can you discuss this tracing? It's an RA tracing. Just discuss. What is the scale? What is the scale? It is not very. What is this?
This is the pressure.
It is a 100 scale, and this is what is the what are the waves in this? Right atrial tracing, I said.
25.
Is written there also, no?
It's written there at the top.
Yeah. Then what is the difficulty?
So it shows a prominent A wave.
A wave, prominent A wave. So prominent A. How much is the A wave?
So around 30 millimeter peak.
How much?
30 millimeters.
30 millimeters. So it's a very prominent A wave. So what are the conditions where you will get a prominent A wave?
So if there is any RV inflow obstruction like tricuspid stenosis, or if there is any pulmonary stenosis, RV,
two types of things. AV valve obstruction, like tricuspid stenosis. If there is a decreased RV compliance, it can be severe pulmonary stenosis with RVH, or it can be pulmonary hypertension. Then you will see, you will be asked about the irregular A waves. Irregular A wave, Cannon waves. Cannon waves are what? What are Cannon waves?
So when the RA contracts against a closed tricuspid valve.
Okay, it is a Cannon A wave, and when it is, you will be asked about irregular and regular Cannon waves. I think you can read. I'm not going to those details. So can you discuss this tracing? Can you see my mouse moving?
Yes, sir.
Yeah. So what is this wave I am pointing to?
So this is likely the A wave, sir.
This why? Because the P wave is here.
Yes, this is the A wave.
And this wave is what?
C wave.
This
is what?
The V wave.
V wave. Okay. So then you discuss what is this tracing. Is it normal or elevated?
Sir, elevated because the yes, sir, elevated.
What is the mean? Approximate mean? Approximate means if you draw
25.
25 or so. It is a mean pulmonary capillary or LA pressure. No, it's an LA pressure. So it is elevated. It's elevated. So what condition could it be?
Sir, any mitral stenosis?
LV inflow obstruction. It could be mitral stenosis. What are the other LV inflow obstructions? You should know about those things. Read about it.
Yeah.
Okay. This is again a pulmonary capillary wedge showing a elevated pulmonary capillary wedge.
Elevated A wave and
Here both A waves and V waves.
And the V waves.
We are not seeing a C wave in all the, there are in between, but mostly we are seeing an A wave. So how will you confirm pulmonary capillary wedge? You are getting a pulmonary capillary wedge. What are the 5 criteria to confirm it is pulmonary capillary wedge? That is the thing. I think it is given here. So it is less than or equal to the diastolic PA pressure. From arterial tracing, we will be going to the wedge position. As we have earlier seen, from a single pressure tracing per cardiac cycle, this will go to a pressure waveform of 2 waves per cardiac cycle. Transition from the arterial to atrial waveform. Then fluoroscopy shows a stationary catheter, and you can do the what is called a flush test. And if you aspirate, what blood will you get? You will get a
fresh,
arterialized blood. You can get the distal port in the occlusion position. So this is how you confirm that this pulmonary capillary wedge. Okay, so can somebody interpret what is this?
The CV is there.
What is this? This is a.
This is the aortic tracing.
First part is what is 2 waves per cardiac cycle. So it is what is it likely?
This is likely a atrial tracing. This is a pulmonary capillary wedge, and there's a pullback into the pulmonary arteries.
No, 3 types of atrial tracing. It can be atrial, right atrium, left atrium, or pulmonary capillary wedge. Okay, so you have a pulmonary capillary wedge. It is already written here. Always see there will be some clues. Most likely it will be written there. Pulmonary capillary wedge, is it normal or elevated? This mean is around 30. So it is elevated.
Elevated.
Okay, and what about the PA pressure?
PA pressure is also elevated.
Elevated.
50 by 20 with a mean of around 25. It is elevated. Okay, so now we will go to the ventricular waveforms. So there are 2 waveforms. One yellow and one is green. Which is which one? Which is RV, which is LV? How will you identify?
So the RV is more
it's already written there, but how will you make out?
So number 1 is
so RV is more triangular, and
RV is a triangular. Why it is triangular? What is dP by dt?
It has a lower dP by dt than the LV.
Lower dP by dt. So that is why RV has a triangular position compared to LV. You can see it is a more rectangular type of tracing. We will discuss in which all situations where we don't have and all we will discuss. So magnitude of the pressure always it may not be. Sometimes you can have a systemic RV pressure also. The magnitude can help, but some of the time it may not help. Morphology we have already discussed. And in the ventricular pressure tracing, what all things should you look at? The systolic pressure, the dip diastole, and the end diastolic pressure. These are all very, very important. So we'll discuss that. The most important pressure in any cardiac measurement is, which is the most important pressure for discussing any hemodynamics?
So end diastolic pressure.
End diastolic pressure is the very most important pressure. Okay. So end diastolic pressure. So where will you measure the end diastolic pressure in LV tracing? So this is the LV tracing. You can see this is the LV tracing. So which point is where you mark the
just before
LV ED point? So you drop a line from the peak of the QRS to the line dropping from the peak of QRS, and where it meets the ventricular pressure tracing, the ascending limb of the ventricular pressure tracing, that is the point called the Z point. It is called the C point. It occurs after the A wave, coinciding with the ECG R wave, and that is the ED point. And what is this D point? What is the D point?
So this is the phase of the where the rapid filling phase ends.
Starts.
From there, the
okay. So what is that D point called?
Is the likely the end systolic pressure that after the isovolemic relaxation.
And it's called a dip diastolic pressure. What are the situations where you will get a dip diastolic pressure elevated? When there is ventricular dysfunction and the patient is on a ventilator, no? You will ask, your patient is on a ventilator and you are doing an LVED measurement and the dip diastolic is high. What will you tell the anesthetist? What anesthetic parameter can influence the dip diastolic? The PEEP. The PEEP can influence whatever PEEP is given, that will be reflected on the PEEP is 5 or 7, then your dip diastole will be +5 or +7. So you should ask the anesthetist to reduce or put off the PEEP for a few seconds for you to measure the LVED PEEP. Okay, always when you do that, when the patient is especially on ventilator. Okay, now we'll go to the arterial pressure waveforms. So this is the aortic tracing and the ventricular pulmonary artery tracing. I think we will discuss it when we discuss each of the some sample tracings are there. So this is the aorta tracing from 2 different points in the circulation. One is ascending aorta and the other is at the femoral artery. So which is the ascending aorta, which is at the femoral artery? The white one is the...
So white one is ascending.
Okay, what all changes happen in the when the pressure wave transmits to the periphery?
So there may be some distal peripheral
all
augmentation.
You are seeing here, you can just
reflected.
discuss. You would just discuss what is seen there.
So reflected wave is prominent at that.
Now, what happens to the systolic pressure?
So it is higher up than the central aortic pressure.
What happens to the diastolic pressure? And all things you have to say. Reflected wave and all, that is maybe the reason, but what do you see? So there is a delayed upstroke. There is a delay in loss of amplitude or absence of the dicrotic notch, increase in systolic pressure and a decrease in diastolic pressure. And these are the changes which happens, and you should know why this is happening. As you said, the decrease in arterial compliance and reflected waves, and that are the reasons for this change. So you should know what happens. You can see the A is the ascending aortic tracing, B is the mid aorta, and C is the periphery, like dorsalis space. Now we will go to some, with this basics, we will go to some tracings for analysis. Guha sir, tell me how many more minutes and so whatever.
You go ahead, I will tell you.
Yeah, you tell me, sir. Then I will stop at that point. Yeah. Okay, so what is this tracing, and tell me, interpret this tracing. This is to make one point, to make you understand one point, this particular example. What are you seeing? You are seeing an LA and an LB tracing. Okay. Is it a, what is your interpretation?
LA pressure is increased.
LA pressure is increased. LVED?
LVED is also increased.
Also increased. Is there a gradient between LV and LA?
Yes.
Minimum.
So it is approximately 20.
Gradient. There is not much gradient now between LV and LA. Very minimal gradient. Okay. So the point is not that. What is the third tracing? Third one. See the ECG in the third one. ECG in the third beat. And see the other tracings, other P waves in the other ECGs, other QRS.
So third is sinus beat, sir.
Third is the only sinus beat. All others are junctional with a retrograde P.
Retrograde.
So what happened? What is happening to that V wave or whatever wave is there? It is becoming very, very prominent. So always look at the ECG before you interpret anything. So that is to drive that point. I will show you another example. What is this? First is first part is what?
Sir, atrial tachyarrhythmia is occurring, sir.
Not tachyarrhythmia. What is it? Is it a normal rhythm or something is it's an artificial rhythm?
So first is the paced rhythm, followed by
paced rhythm. Okay, and followed by the sinus rhythm. And what is happening to the pressures? What is happening to the pressures? What is the
increase in the
pressure when there is a sinus rhythm? So what could be the reason?
Sir, RV pacing.
RV pacing? Why the pressure is low compared to when there is sinus rhythm, the pressure is higher?
So there is a decrease. Means in RV pacing, there is a decreased blood in the LV during the end diastole, sir.
Why?
Sir, because there is a atrioventricular.
So basically, what is there? You have an atrial. Okay, I will show this tracing. That will be give you the answer. This is of one of our patients where you can see the first three tracings are okay. The patient who had an MI, primary angioplasty was being done. You can see the first three tracings have all the others, all the tracings with that arrow, all arrows indicate P waves. So even when there was an abnormal conduction with a P wave, you can see that the pressure was normal. But when the P waves were lost or P waves were not seen, the same morphology, you can see that the pressures were low. So this indicates what the contribution of the atria towards the cardiac output. Okay, so this is to drive the point that you always look at the ECG before interpreting any cardiac, any hemodynamics, and that will be very, very crucial in the assessment. Now we'll go to some of the tracing. This is the tracing which we discussed. So tell me what is this and what is your interpretation?
So this is a simultaneous tracing from the LV and the aorta. There is showing a gradient of around 80 millimeter between the LV and the aorta. So likely an obstruction at the LVOT.
LVOT obstruction. What type of LVOT obstruction?
So likely fixed obstructions.
Fixed obstruction like a?
Aortic stenosis, sir. Valvular
aortic. Valvular. Okay. Okay. And why you say it is valvular?
So when there is a slow rising of the aortic pressure, there is a slow rise.
Pressure peaks towards the end of the systole. Okay. So that is what. Okay. So these are the three tracings, three LV and aorta. Three types of gradients are shown, A, B, and C. Tell me what is A, what is B, and what is C. What is A?
So A is the pulse pressure.
No, peak to peak.
Oh.
It's LV and aorta. So what is
the type of gradient?
Peak to peak. Oh, peak to peak gradient.
Peak to peak. Where do you get the peak to peak? What type
from
of
the
where will you get it? Peak to peak. If you want to measure the peak to peak gradient, what can you do?
We measure from the peak of the two pressure curves.
How will you do it? Do it in the cath lab? How will you do it? Or how will you do it in the echo? How do you do it? Peak to peak, you measure the cath lab by doing a pullback or doing a simultaneous pressure tracing. You do peak to peak. What is B?
Mean gradients.
No,
mean
not
gradient.
mean.
No. C is the mean.
Mean is C. B is instantaneous.
Peak instantaneous gradient. Where do you measure it?
On echo.
Peak
instantaneous. Doppler always gives you the instantaneous.
Peak instantaneous gradient. Okay. So that is how you should know these types of gradient in aortic stenosis. The peak to peak, which you measure in the cath lab. B is the peak instantaneous you measure in the echo. And C is the mean gradient where you calculate by the whatever formulas. Okay, we will not discuss that. So this is a patient who underwent an intervention. Tell me what all changes has happened. first set of tracing is almost the same thing which we have discussed. And subsequently, something was done, some intervention was done, and what has happened? Just tell me.
So after the intervention, what
is the diagnosis?
So this is a LVOT obstruction, likely aortic stenosis. There is
what is the gradient?
The gradient of around 100 millimeters, sir. 100 millimeter Hg.
Okay.
Look at the top, it is mentioned.
It's 400, no, it is 400. So each will be how much?
Oh.
Okay.
Written there. It's written up there.
It is written on top.
258 by 108.
108. So, it is the gradient is around 140.
Okay. Yeah.
Harikrishnan, just I am mentioning for their interest. I don't take much time. If this top one is masked, the digital values you cannot see, you have to extrapolate what is the length of the scale means. Here you see 400. So each division should be 50. From that you can calculate.
Yeah, sure. That's right.
Correct.
In fact, they should do that.
Yeah. Okay. And subsequently, this is a very significant LVOT obstruction, probably a valvular
aortic stenosis.
Aortic stenosis. Then subsequently, what happened? Some intervention was done. What has happened?
So the LV end diastolic pressure increased. End diastolic pressure increased, sir.
Okay.
It is.
What is what happened to the gradient? It's a pullback.
The gradient has decreased. The gradient has reduced, but the LV-EDP has increased, sir.
And what? Not LV. Okay, LV-EDP. That is a tracing. It is a pullback. So
pullback.
Okay. So what happened?
Yes, the diastolic pressure has decreased. So the patient might have. So the patient might have developed aortic regurgitation.
Very good. Aortic regurgitation. And one more thing is there in the pullback. From the third tracing, so from here, there's a gradual rise in pressure. Can you discuss what it is? What is that called? There's a gradual rise. Forget about this one. Just from the third, what is that? The second true aortic pressure tracing from
what
here.
Is the name of that effect? That's what we want to know.
What is that called?
It starts with a C.
The Corvallis sign.
Okay. What is it? Can you discuss it? What it is? That is called a pressure recovery. Pressure recovery. Pressure recovery means just immediately after the valve, there is a loss of pressure due to the dissipation of the pressure wave. Subsequently, it recovers. This is called the pressure recovery. Okay. So these are the two types of tracings in LVOT obstruction. Tell me what is the first one and what is the second one.
So the first one is a dynamic LVOT obstruction, and second one is likely to be a fixed LVOT obstruction.
Fixed LVOT obstruction. So what is that first pattern called?
The spike and dome pattern.
Spike and dome pattern. Okay. So that is a spike and dome pattern, and the second is a slow rising. As you see, the peak of the aortic tracing is towards the end of the systolic, the descending wave of the LV trace. Okay, tell me what is this?
Sir, ventricular ectopics increases the subsequent systolic pressures. Systolic.
Okay.
Sir, it is gradient approximately 240, sir.
Okay. Tell me what is it? What is this called?
So this is the Corvallis sign, sir. Likely.
Corvallis sign. Corvallis sign is something different.
This increase in pulse pressure after premature ventricular beats, sir.
Increase in pulse pressure. Okay. So what is that? What is the type of obstruction? Okay, I will show you another tracing. I will show you another tracing. What is this?
So this is broken Brown-Wald. So this is broken Brown-Wald phenomenon.
Okay, what is the characteristic feature of a broken Brown-Wald phenomenon? Because both are ectopic.
There is a decrease, sir. There is a decrease in pulse pressure following.
Very good. So that is the important point you should understand. In a broken Brown-Wald, you should have the pulse pressure should be much lower than the first beat and the pre-ectopic beat. That is the most important point you should. So I will come back to the first one. You can see that here also there is an ectopic. This is also an LVOT.
But it's not.
But there is no reduction in the. And here also you can see it is a slow rising pulse. So it is a fixed.
Yes,
so broken Brown-Wald phenomenon occurs in a dynamic obstruction. Okay. So this is what the pulse pressure post-ectopic beat is the most important, and it should be lesser than the previous beat. That is a classical feature. Okay, what is this tracing? Symbol 1, pullback.
So this is a pullback from the, so likely from the ascending aorta to the more distal, distally, showing a gradient. So likely, they're likely to be coarctation, sir.
Very good. Coarctation. Could be some obstruction somewhere in the aorta. Most likely it is a coarctation. You can get this similar things in which other condition also. Like in aortoarteritis also you can get mid-aortic obstructions also you can get. So this is what, this is something else has done. What is this? Similar tracing. So again a pullback. Pre-angioplasty and post-angioplasty. What angioplasty is done?
This is a coarctoplasty.
Coarctation. Agreed. What is this tracing? Again, we are now concentrating on the LVOT obstructions.
Subvalvular. So subvalvular obstruction is there.
Subvalvular, no. Not subvalvular. Subvalvular.
Sorry, sir. Supravalvular, sir.
Supravalvular aortic stenosis. Supravalvular aortic stenosis, where there is a wide pulse pressure in the supra-aortic valvular chamber. That is what the supravalvular aortic stenosis. Okay. What is this one?
This is subvalvular aortic stenosis, sir.
Subvalvular. Here, why it is
because in the ventricle only there is a decrease in the pressure.
In the ventricular tracing itself, because it is ventricle, because it is touching 0. And you can see that there is a gradient with the morphology of the ventricular tracing. There is a gradient between this wave and this wave. That indicates a subvalvular gradient. And there is no further gradient between the subvalvular region and the aorta. So basically, there is only one gradient that is below the valve. That is a subvalvular gradient. So subaortic subvalvular. So these are the 3 tracings you should know. Subvalvular, where there is a ventricular type of tracing with a gradient inside the ventricle. Here valvular, we have already discussed. It's a slow rising. Here you can see a supravalvular gradient where the supravalvular chamber will have a wide pulse pressure. So these are the things. Okay. Discuss this tracing. We have discussed it before also, but yeah. What is this wave?
So this is the A wave.
Yeah, this one?
V wave.
C
wave. And this is?
C wave. This is the V wave, sorry.
Yes, this is the V wave. So what is the mean LA pressure?
Mean elevated, sir, around 24.
24. What is the mean LVED? Almost 8, around 8 or just slightly more than 9 or something. So what is it? 9 LVED and 20
mitral stenosis.
Severe mitral stenosis. So is it mitral stenosis or there is mitral regurgitation also?
So with elevated V, MR is also a possibility, sir.
But I think Dr. V.S. Narayan also will agree, and Dr. Chandragu also will agree that many a times when we do mitral valves, we see the V waves are
also
much
prominent.
higher. Yeah, so it is.
Yeah, so I don't think it has significant MR.
Correct, sir. So most of the time, whenever we do, we see the V waves, especially in juvenile mitral stenosis, where the LA compliance is not that great. In that case, the LA compliance is relatively poor. In that case, also, you will see a prominent V wave.
I'll just ask a simple question on auscultation, whether this patient would have presystolic extension or not.
Yes, sir, they will have.
Okay, please go ahead.
Okay.
Sorry.
Harikrishnan, how many more slides you are having?
No, I will stop at whenever you say, sir. I have more slides, but that doesn't matter. I will stop at whatever point you say.
No, I just wanted to have this discussion because hardly these things are done routinely in the cath labs. So these guys are not exposed to it. So I thought let them have a look at what are the tracings and how to interpret that. Anyway, it's the excellent one. Just you show two more tracings and then we move on.
Sure. We can have it on another day also.
Yeah, sure. You show two more tracings.
Yes. Okay. So this is the left atrial tracing. There is a severe mitral stenosis. So this is A, C, and V wave, LVAD. And this is again another tracing. This is a pregnant patient with severe mitral stenosis. You can see that the V wave is so high. V wave is around 60. This is a patient which was planned for absolutely very trivial MR or absolutely no MR. You can see that the V wave is significantly higher. So that is always we have seen. So what is this intervention done, and tell me what it is?
Some BM
done, and you can see the excellent result. This is what we call the kissing tracing. There is absolutely no gradient between the LV and LA. So very gratifying result. Sometimes we get this. So unfortunately, what is this? It's another tracing.
So there is regurgitation occurs, sir, post.
Okay. There is you can say that you interpret the tracing. Don't suddenly jump and say regurgitation. What regurgitation? So the LA pressure is?
Yes.
Are you seeing a wave or a V wave?
Sir, V waves.
So V wave. V wave is reaching up to 100 millimeters of mercury. And what is the LV pressure? LV pressure is 180.
Around 180.
180.
200.
So this is a post-BME patient. Will you send we keep the patient on medical treatment, or will you send the patient for immediate surgery from the cath lab to the theater?
Sir, immediately sending the patients.
What is the criteria? The V wave is more than 50% of the LV pressure or the aortic pressure. Then you have to send the patient immediately for surgery. Otherwise, what are the indicators? Now the patient develops MR. What are the indicators you look for to assess the stability of that patient? So whether you should immediately call your surgeon friend and wheel it to the theater, or you can wait till his case is over. What are the pointers after a BME? One is the pressure tracing, as we said, more than 50% of the V wave. What other parameters?
Sir, hemodynamic stability.
Okay. The blood pressure. Then?
And acute pulmonary edema is...
Orthopnea.
Orthopnea symptoms, agreed. Saturations. If there is a drop in saturation, you should immediately check. This tachycardia. All these things you should monitor. The gradual drop in blood pressure, increase in the heart rate, a decrease in the saturation. You should send the patient immediately for surgery, even if the V wave was not tall or anything. So these are immediately you should shift the patient and have a very close monitoring of the patient. You can lose the patient. Suddenly the patient go into pulmonary edema and we may not be able to save the patient. But this patient, if surgery is immediately done, the patient can be saved. So this is acute MR hemodynamics versus chronic. So I think we will stop here, sir. So other tracings.
Thank you. Thank you very much. So but we'll have this thing on another day. And one thing what we didn't touch today about the analysis of the oximetry data.
Yeah, that we can do.
Very important for them. We'll have it on another day. The rest of the hemodynamics and some analysis of the oximetry data cases.
We can do
We'll
it.
have that.
We can do then some more tracings also, like we didn't discuss about the RV, pH and all. We didn't discuss.
These are the questions which are usually asked during the exams.
Then about constriction, restriction and all, we didn't discuss that. All those things we can discuss on some other.
Yeah. Thank you. Thank you very much.
Thank you, sir. Thank you very much.
Thank you from my side also, both of you.
Wonderful.
Thank you, sir. Thank you so much.
Wonderful. And let us proceed to the case. Bipul, sorry, we are a little late, but you please start your case.
Sir, is it visible too?
Yeah, it is visible.
Yes.
Go ahead.
Thank you, sir, giving me opportunity to present a very good case of congenital cyanotic heart disease. Sir, I am Dr. Bipul Rai, third year PDT from the Calcutta Medical College. Sir, can I proceed, sir?
Yeah, please
carry on.
Sir, my patient is S. Malakar. She is a 47-year-old. Occupation is housewife. Education status, she has read up to class 7, residing at the Shatragachi, Howrah. Came to us with a chief complaint of bluish discoloration of the leaf and fingers and toes since 1.5 months of age, breathlessness on exertion since half years of age, and recurrent hemoptysis since last 3 years of age.
Kandanu, how much time do you have for the question answer session?
Actually, we are supposed to, if we finish it by 10, we'll extend it by another 10 minutes. We'll have 40 minutes discussion altogether.
Because the issues that will be asked from whom the history was taken and how the patient could pinpoint the duration and onset, etc. Because in the adult congenital heart disease, we often miss these points.
Okay.
Sir, may I proceed, sir?
Please.
Sir, history has been given by mother and patient herself, and it's reliable. She was apparently well until 1.5 months of age, until mother noticed mild blackening of the lips and finger and toes and the other part of the body, which worsens with the crying and that decreased with the coming by the mother and holding her in the knee chest position. Each episode lasted for 3 to 5 minutes. Frequency of such episodes increased over the next 1 to 1.5 years until 2 years of age. After that, the frequency of those episodes decreased. There was no history of associated convulsion and loss of consciousness during those episodes.
Who told the mother to hold the baby like that?
Sir, actually, in the first, mother doesn't know, but gradually she noticed that by this position, baby is coming down and the cyanosis also decreased.
Okay. So don't give a very perfect history when you present an actual case in the examination, such as, disappearance of the squatting phenomena at the age of 2 years. This is classical book picture. So don't try to do that in the examination.
Yes,
an actual examination when you present this case. Okay, carry on.
As the baby grew up, mother noticed that her child was relatively less playful than the others and used to avoid playing that required higher physical activity, and frequency assumed squatted position during the playing. She also complained of the breathlessness during the exertion since 2 years of age, suggestive of Ross class 2. It was more or less remained in the same class. Mother noticed bulbous enlargement of the all fingers and the toes at around 1 year of age and progressed gradually over the next few years. At the age of 3 years and 2 months, there was history of repeated episodes of coughing out of blood without any associated fever. Amount of blood was approximately 1 teaspoon during each episode. She was shown to cardiology department in the Medical College, Kolkata. At that time, she was admitted to hospital and some sort of major surgery done at that time. Total duration of hospital stay was 2 months around, and after which her complaint relieved somewhat and breathlessness became class 1. Second surgery was advised, but she lost to follow-up.
Second surgery was advised after how many years?
Sir, mother can remember that, sir.
Okay.
For pretty long time, she remained in the NYHA class 2. For last 1 year, she complained of progressive increasing in the exertional breathlessness and fatigue, and now she is NYHA class 3 symptomatic. She also complained of frequent episode of coughing out of blood for last 1 month, and amount of the blood is mild and it is not associated with any fever. This time also. There is no history of swelling of the feet or abdomen, no history of headache or lower limb ulcers, no history of palpitation. Sir, with the past history, no history of admission for the lower respiratory tract infection, no history of tuberculosis, diabetes, or hypertension. Regarding the personal history, menstruation normal in amount and flow, as the patient says. Bowel bladder is normal. No addiction is there. Decreased appetite for long time. Maternal history, no history of diabetes mellitus or hypertension or any other major illness or regular drug intake. No history of fever with the skin rashes during the gestation, as told by the mother of the patient. Pregnancy history, 3 fetal loss, 2003, 2004, and 2006 at second trimester. Drug, there is not on the regular medication at all. Now regarding the development history, she has the head holding approximately 3 months to 4 months of age, standing around 1 year and 2 months.
Milestones normal or delayed? You cannot.
Sir, slightly delayed, sir.
Go ahead.
Sir, with this background, the summary of the history: 47-year Hindu married female, present with the bluish discoloration of the skin and the mucous membrane and other parts of the body since 1 month, 1.5 months of the age, with history suggestive of cyanotic spells, which decrease after 2 years of age. She also had history of the clubbing of all fingers and toe since 1 year of age and increased gradually over the next 2 to 3 years. She had history of exertional dyspnea and fatigue since 2 years of age, with history suggestive of squatting to get relief of her symptoms. At age of 3 years and 2 months, she had undergone some major cardiovascular operative procedure, after which her symptom relieved somewhat, and her functional class improved. She lost to follow-up and now presented with the class 3 fatigue and dyspnea with frequent mild hemoptysis. See also history of 3 fetal loss in between.
Don't show the DD.
Don't show the DD, just tell us what you think.
What is the provisional diagnosis? What are the differential diagnoses? Discuss those things.
Sir, as there is a classical history of the cyanotic spells and the squatting, it is we are dealing with the congenital cyanotic heart disease with low blood flow.
Just from these two things, that is squatting and dead spell, do you arrive at the diagnosis, or you take into consideration onset of cyanosis, progress of the disease, days of onset, etc. also, and survival till adulthood.
Yes, sir, definitely, sir.
So these points have to be discussed. Otherwise, you cannot discuss the differential diagnosis.
Yes.
Go ahead.
Sir,
probably. What surgery do you think she had at this? Obviously, this is a reduced pulmonary blood flow situation. And what kind of surgery do you think she had? Did she have a scar in the center, or should she have a scar in the side?
Lateral.
Sir, in the lateral, sir.
So what do you think she had?
Sir, as the mother advised for the second surgery, so it is probably a palliative shunt was done at that time.
Shunt surgery was done. And then what happened gradually? Now why she is back into increased cyanosis and fatigue and hemoptysis?
Sir, patient...
Is shunt patent or not?
Sir, probably shunt is not patent, sir.
Did the cyanosis increased?
Yes, sir.
So you think something has happened to the shunt? Or what else can have happened, could have happened?
Sir, another might things have happened that patient have a progression of the cyanosis and the breathlessness. With the frequency of the hemoptysis, there is a rupture of the aortopulmonary collaterals.
No, that is the cause of. We're not asking you the cause of the hemoptysis. We're wanting to know why her symptoms had gone away to a large extent and now they've come back.
Sir, maybe sir, due to the RV dysfunction or patient have some sort of hypertension or systemic disease, sir.
Okay. So you think there's something happened as far as the, on top of the tetralogy or that kind of situation, she has got what we call an adult type of heart disease, congenital heart disease. And you think she has probably had an aortic regurgitation or hypertension or right ventricular failure, things like this.
Yes.
Yes. Could she have developed pulmonary arterial hypertension because of increased flow through the shunt?
Sir, could you get the question?
Yes, sir. Sir, hemoptysis is the against factor, sir.
Hemoptysis you could get with pulmonary arterial hypertension also. Okay, let's go ahead and discuss the differential diagnosis. So a shunt surgery was done and probably that shunt is not working or something has happened on top. Patient could have gone into left ventricular failure because of AR or because of development of hypertension. Could have gone into right ventricular failure and all those things. But perhaps increase in cyanosis, probably not because of these things, could be because of the failure of the shunt to have functioned well, and probably over shunting also could happen. But then she doesn't give history of any increased respiratory tract infection. So that is not a very good possibility, but should be considered also.
Okay, sir.
Okay.
Sir,
discussing the differential
diagnosis. Now you can go to the list and tell us.
Sir, with this background history, my first DD was Prof, classical. Second is DRB VSDPS. Third is single ventricular PS, and then is CCTG VSDPS.
So basically tetralogy, physiology, and the classical TOF. Okay.
Yes, sir.
Why have you left out detransposition?
Sir, number one, the cyanosis may present at the birth, and with the survival of this age, it is not possible beyond the TOF classical.
Okay. So tetralogy, physiology, as Dr. Dev says, and all the differential diagnosis within tetralogy, physiology, you would consider, and the top of the list would be classical TOF.
Yes, sir.
Because you have so much.
But when you discuss the tetralogy, physiology, you have to have certain deviation from the normal history of tetralogy of fellow. You get something like that, or you do not get?
Sir,
so in that case, tetralogy classical, the probability becomes very high.
Sir, number one is the onset of cyanosis is a little bit earlier, 1.5 months of age.
Anything
what
else?
Percentage of tetralogy will have cyanosis at birth? It is not always delayed. See, 25% of them will have cyanosis at birth also. About 70%, 75% will have delayed onset of cyanosis because of several reasons which you already know. But it is not that, always there would be a delay. But if it's a delay, yes, tetralogy, physiology becomes a bigger possibility vis-a-vis the transpositions.
Okay, go ahead. Go ahead to the exam.
Sir, patient is conscious, alert, and oriented. Build is average, but BMI is 15.8 kg per meter square. Decubitus of choice. Respiration is 24 per minute, thoracoabdominal. Cyanosis is central type. SpO2 measured in the 75%, it is equivalent in all 4 limbs. Clubbing, it is grade 3.
In case of long case, if you have sufficient time, you give the actual height and weight before discussing the BMI, because you are talking about the Bilt's average. Okay?
Yes.
Go ahead, please.
Sir, clubbing is grade 3 involving the all fingers and toes. Icterus is absent. Edema absent. Conjunctival plethora is
present. What does it mean by grade 3 clubbing?
Sir, there is a parrot breaking of the finger, toes and...
Okay, why it is not grade 4?
Sir, if it is involved the wrist joint.
So you asked and looked for it?
Yes.
Okay.
Go ahead.
BP is upper limb is 110 by 70 and it is equivalent to all the limbs.
Left or right?
Sir, it is right side.
Mention.
Go ahead, please.
The pulse is 88 per minute, regular, no special character is there. Normal in volume, no radio-radial or radio-femoral delay is present. It is equally palpable in all 4 limbs. Arterial wall is not palpable. JVP is not raised. AO wave is prominent. Hepatojugular reflux is absent. Skin is no specific changes seen in the skin.
What is the complexion of the patient?
So she is little bit black
Okay.
complexions.
Dark complexion.
Darker complexions.
Go ahead.
So with the inspection and palpation, there is a scar extending from the anterior to posterior part of the chest, approximately 10 centimeter in the length. That is in the right side. And apex is RV type. It is 4th.
No, you have mentioned right side, anterior, posterior. Any intercostal space can you mention?
Sir, it is 4th to 5th, sir. 4th, sir.
Any evidence of rib dissection, narrowing of the intercostal space, any deformity of the chest and spine?
No, sir. There is no specific deformity, sir.
Why is Dr. Sab asking about the deformity in the spine?
Sir, maybe associated with scoliosis.
Yeah, because cyanotic heart disease does have some kind, in certain cases can have. Rightly said. Okay.
So apex is RV type involving the 4th and 5th intercostal space. It is 2 centimeter inside from the MCM, mid-clavicular line. Epigastric pulsation.
No. One very important point about the apex. It is left-sided or right-sided?
Sir, left side, sir.
Please always mention.
Yes, sir.
Right.
Sir, epigastric pulsation is present. There is grade on parasternal impulse is present. Pulsation of right sternoclavicular junctions palpable.
What does it point to?
Sir, there may be probability of the right-sided aortic arch, sir.
Anything else? Okay, go ahead.
So regarding the percussion, the upper border of liver dilatation is 5th intercostal space.
Left side, right side?
Sir, right side, sir. Sir, left second intercostal space is resonant. Regarding the auscultation, S1 is normal, S2 single, probably A2, and it is loud. Vascular ejection click present in the aortic area. No other murmurs heard all over the precordium.
Inspiratory or expiratory increase in the ejection click?
So there is a respiratory variation is there, sir. It is inspiratory, sir.
So do you think click is what?
So it is a, sir, aortic vascular click.
Yes.
So dilated aorta, okay, go ahead.
So the pulmonary ejection click should not vary in the presence of a VSD, but an aortic click can vary with respiration, especially if there is an overriding of the aorta. You can have a variation in the aortic click also. So rightly said, it's a vascular ejection click on the aortic origin.
Sir, examination of the other.
You have written no other murmur. What are the areas you look for the other murmur?
Sir, all over the precordium, also in the back.
Any lateral side of the chest?
Yes, sir.
Why did you spare the lateral side of the chest?
Sir, actually, I have forgotten to say.
You have forgotten? I mean, you forgot to mention or forgot to
Sir,
examine?
forgot to mention, sir.
Okay, now mention it. And any infraclavicular murmur?
No, sir.
So why am I asking all these questions? And why are
Why
you
do
allowing?
we want to ask of another murmur in this case?
Why do you allow me to ask? Why don't you come spontaneously?
Sir, number one, patient has undergone some palliative surgery.
Okay.
That may cause, and second one is
that may cause what? That may cause what?
Sir, continuous murmur in the
where?
Sir, in the right side of the chest back.
Okay. And what else?
And another one is the patient is survival is beyond 40 years and still the patient is relatively doing well than the others. So there is a possibility of MAPCARS is there. Sir.
Okay.
So the absence of murmur of the shunt probably goes with your diagnosis of a malfunctional situation. And that is the reason why she's back into cyanosis and hemoptysis.
That is one thing. Another thing is, if you do not find any murmur, does it mean that there is no MAPCA?
No, sir, because the bronchial collaterals doesn't produce any murmur.
No, bronchial collaterals are not MAPCAs. You listen to the question and answer.
What did I ask?
You said
whether the absence
of a murmur, does it mean that MAPCAs will be absent?
I didn't ask you, sir. I'm a too small person to ask him questions. Okay, I was asking the student. Okay, go ahead.
No. You said that. So I said you were asking.
He's reiterating what you said.
Yeah. And then he said that it is bronchial murmurs will not be heard. To which Dr. Goa said that bronchial collaterals are very different from MAPCAs.
Okay, people, go ahead.
Sir, with the examination of the other system, respiratory system, it is respiratory rate is 24 per minute. It is thoracoabdominal. Bilateral symmetrical movement of the chest seen. Pectus carinitum is present. And palpation, trachea is shifted to the left. Percussion and auscultation, it is normal. GI system, palpation of the liver in the second.
Do you say trachea shifted to the left?
Yes, sir.
So, or you were talking about the relationship between the pulsation and the trachea?
Sir, pulsation is the right sternoclavicular.
Okay, when we come to the X-ray, we'll be re-asking you this question. Fine.
Yes. So, palpation of the liver is palpable 2 cm below the right costal margin, and percussion gastric tympani is tympanicity is seen in the left. Other finding is normal. CNS system, patient is conscious, alert, and cooperative.
What is drop space?
So, drop space is the percussion of the percussion of the.
I'm not talking about percussion. I'm talking about what is drop space.
Drop space.
Okay, maybe you have forgotten. Fine, carry on.
So, sir, my diagnosis is situs solitus. It is levocardia, congenital cyanotic heart disease with low pulmonary blood flow in form of tetralogy of Fallot. No pH, no features of CCF or infective endocarditis. Patient is now sinus rhythm. Now she is functional class 3.
No,
why undergone the major surgery?
Percussion in the second space, you said the second space is dull.
Yes, sir.
Resonant.
Resonance.
Is resident. Oh, sorry. I'm sorry. I thought you said.
No, you have to tell us about the shunt.
So status post-surgery.
No, post-surgery, what surgery?
What surgery?
Sir, palliative procedure.
Yes, palliative procedure. So it's a kind of shunt.
Yes. Sir.
So shunt is closed or functional?
So shunt is closed, sir.
Okay. So why did you mention these things? Okay. Any other? Have you completed the diagnosis, or still you have written something else?
Sir, diagnosis part is complete, sir.
Completed. So any other features that may happen, for example, AR, heart failure, etc. Dr. Narayan was repeatedly asking you why the patient has gone downhill lately.
Sir, I have suspected it, but
clue, because you have now finished up everything. So you should be able to tell us all these things. Maybe you are not correct. We also do make mistakes.
no, sir, definitely, sir. But regarding the finding, there is no clues regarding the AR sort of things, sir.
Sort of thing, any other thing? I just gave you an example. Any heart failure?
No, sir.
Okay. How do you diagnose anemia in such a case?
Sir,
is she still menstruating?
Yes, sir. Patient is still menstruating.
Okay. So how do we diagnose anemia in such a patient? History of hemoptysis. Though it is stated to be normal menstruation, maybe she is having a bit more from the very beginning. She doesn't know what is
answer
normal.
that question. How do you recognize anemia? That is important, very important here.
That will always be asked, actually.
Sir,
No, it's not a very difficult question
no,
to answer.
You said liver is palpable, isn't it?
Yes, sir, palpable, but span is normal, sir.
Span is normal. Okay, fine. Any edema?
No, sir.
Arindam or Aditi, anybody wants to take that question? How you recognize anemia here?
Sir, we might do a serum ferritin level.
The number one is hemoglobin is 14, less than 14.5 gram per DL.
Okay, that is one.
And number two, PCV is less than 55.
Mean corpuscular hemoglobin concentration.
MCHC.
So why it has been asked, how do you recognize anemia? So clinically it becomes difficult in presence of cyanosis, number one. And number two, anemia has to be recognized and to be treated. And number three, just normal level of hemoglobin doesn't exclude anemia in these ladies. You told us below 14 means anemia. May not be happening so. Why the hemoglobin is raised normally? Normally means in these patients.
Sir, because of chronic hypoxia, there is a stimulation of the erythropoiesis.
So in any case of cyanotic heart disease, this will happen. Okay. So these questions are common and you will have to face. And if you cannot answer this, at least this type of common question, it becomes a major negative feedback. Okay, go ahead.
Sir, ECG shows that patient is in sinus rhythm. Rate is approximately 90 per minute. Tall P wave is there. Axis is 130 to 140 degree approximately. And
the right axis clearly. Now regarding the P waves, do you have to say something?
Yes, sir. It is tall P wave is there.
That is in the precordial leads. And what about the V1 lead?
It is our left atrial energy. Features of left atrial energy is there.
So what is your interpretation from these two leads?
So, there is biatrial energy possibilities.
Normally in tetralogy of Fallot, the left atrium is large or small?
So normally it is small, but if there is a good amount of pulmonary blood flow, or that may increase, sir.
Any feature of volume overload in the left side? Yes or no? It may not be. I don't mean it has to be present.
How do you look for volume overload at the LV?
Sir, it is the presence of Q wave in the V5, V6.
So you straight
it's not there, no?
Yes.
Any transposition feature?
No, sir.
Where do you look for the Q?
Sir, Q for the 2,3 AVF.
So there's absence of Q from 2,3 AVF.
Sir, and V1, sir.
V1.
V1,
you
sir.
have a Q wave in V1.
And if you don't have Q in the V5, V6, and they are present on the V1, V2, that means something. So you have to be able to interpret all these things. And there are deep S waves in V5, V6. In earlier days, we used to discuss about clockwise rotation, counterclockwise rotation, etc.
Yes.
Okay.
No, it's often asked this, clockwise and counterclockwise loop is still asked by, examiners like us, who aged out, talking about clockwise and counterclockwise.
Sir, I was talking about rotation, not loop.
Okay, okay. Sorry.
Okay.
So why do you get this kind of pattern in tetralogy of Fallow? This dominant R in V1, a big S wave in V5, V2, a transition somewhere in V4, V5, and then deep S waves in V6. You know the theory behind why do you get these changes?
Sir, there is a window effect, sir. No, sir.
The appearance of deep S wave is because of hyperplasia of the trabeculae.
Yes.
Dominance of R, of course, and the dominance of S here in V6 is because of RBH. And you have
peculiar thing is R waves are rather monotonous from V1 to V6. V1. There is no that early deprivation, I mean early transition has occurred or something. This is a bit unusual thing. So we have to keep these things in mind that there are certain unusual features in the ECG.
One very interesting thing in the ECG, leave aside V1, from V2 to V6, a pattern is almost similar as if you are moving away from the source.
Yeah, that's right. We did expect some R wave in at least V4, V5.
Definitely. This looks highly unusual.
So that is the thing I was pointing, Shantanu. Yes, correctly said.
Yeah.
The rotation.
Monophasic waves.
Okay, go ahead.
Go ahead, show the X-ray. That will be interesting, yeah.
It is a skygram of the chest showing there is...
She does have some abnormality of the spine, which you possibly missed.
Yes, sir. There is a mild scoliosis is there, sir.
And whether it's a properly positioned X-ray or not, first of all.
Sir, it is not properly positioned, sir.
Why do you say that?
Sir, because the distance between the midline to sternoclavicular joints is
where is the midline? How do we get the midline?
The spinous process of the...
Okay, spinous process.
That's right.
Can you take your arrow and point towards the spinous processes?
Yes, yeah. Take it.
So
Good.
from there to the medial and the lateral, I mean on the left and the right side, is it equidistant or not?
No.
No, sir.
And looking at this trachea, did you say that the trachea is shifted to the left? Sorry.
Left, sir. So there is also rib notching is there, sir.
Yeah. And what about the aortic arch position?
Sir, aortic arch is right-sided, sir.
Okay.
So what do you think is the cause of the notching?
Sir, it is a galactosing shunt. It is unilateral.
Because of the shunt. That's right.
So now did the X-ray in the classical way it has to be done. We have asked you sketchy questions just to get at the prominent things. But go into the proper type of thing, that is position, exposure, bones, everything.
Yes.
So start with situs, then go to the bony abnormalities, positioning, everything.
Sir, there is gastric.
Okay, situs is solitus. But when you begin reporting the X-ray, always mention the situs.
Yes.
Do you think the diaphragm is at the normal level? Is it inspiratory film, expiratory film, or something like emphysema?
Sir, lung field is look like
cut while doing the surgery. So you have to, I mean, look into the bones carefully. First of all, the vertebral exposure is quite dense. That means it is a bit overexposed film. And you can trace the bronchus left one right up to the bottom. That means this is quite overexposed film. And whether the vascular pattern is normal distribution pattern or abnormal. So tell us the X-ray in details. We'll give you 3 minutes time to do that.
Sir, it is a scarogram of chest showing the patient have a situs solitus with a liver in the right side and the gastric shadow in the left side. The LV...
Is it gastric shadow or the colonic shadow?
Sir, this one is gastric shadow, it is the colonic shadow, sir.
Okay.
Sir, patient has a levocardia and apex is RV type, upturned, but the cardiac ciliate is normal. Normal size, sir, with the pulmonary bay is
there is some translucency when you look at the base of the heart and the diaphragm. We normally don't get it like this. So what could be the reason? Could you get my point? The heart doesn't appear to be just sitting on the diaphragm. There is some amount of translucency. And it is not a chylide, it is simple.
No, sir. Yeah.
Okay, go ahead.
Sir, with the pulmonary vasculature regarding the pulmonary lung field, it is lacy pattern is there. More in the
no pulmonary vasculature. What about the infundibulum?
Sir, pulmonary bay is empty, sir.
Empty. So infundibulum is hypoplastic or not? Main pulmonary artery trunk is well seen or not?
Sir, it is not well seen, sir.
Okay.
Then you not talked about the arch, the aortic arch.
No, he told it is on the right side, but this
right
time
side.
While repeating, he didn't tell this. At the outset, he told it.
Okay.
Okay. So vascular pattern is normal or abnormal?
So there's a lacy pattern is there, sir.
Okay, so it is number one is oligemic, though it is very difficult to comment from the overexposed film, and the normal distribution pattern is not like this, it's abnormal. So reticulations are seeing, indicating?
Sir, there is MAPCAS.
There are collaterals, yes.
Okay, then go ahead.
Is there any seventh rib? I mean cervical spine, cervical rib, sorry.
No, sir.
Okay. No, go to the other things.
And just say collaterals, don't go to MAPCAS, straight away you're causing MAPCAS.
Yes, better to say it is collaterals.
Okay, sir. So now...
Who did the echo?
Sir, myself, sir.
Okay, you recorded it?
Yes.
Okay. Well, your machine was good?
Yes, sir, it's Philips Acuity, sir.
And study, you are happy with the study or any problem with the window?
Sir, I have a problem with the window, so it is poorly visual.
So you have to state that out at the outset that you had certain problems with the recording. So it is the, I mean, intercostal space problem was there or subcostal angle was narrow. What kind of window problem?
Sir, the rib crowding is there, sir.
Okay.
Because of pectus carinatum and...
No, you are now mentioning about pectus carinatum. You didn't mention it earlier.
Sir, I have mentioned in the...
He did mention.
Sorry.
In the exam.
I may be...
Before, we did it fast. It is already 10 minutes past 10.
Yes, sir.
We need to keep a watch.
Sir, now
5 more minutes.
It is situs solitus. So it is a parasternal view that showing there is a large...
large what?
Sir, the malposition BSD with the overriding of the aorta, and there is a.
You call it malposition VSD or malaligned VSD?
Sir, malaligned VSD, sir. Sir, with
how much is the override here?
It is more or less approximately more than 50%, sir.
Okay. So by surgical definition, would you call it DORV or tetralogy of Fallot? By surgical definition.
Sir, Kunas tissue?
Yeah,
no.
Echo is something. Echo is something. Clinical is something. Measurement wise
then
something.
1.5 great vessel arises from one ventricle. It is said surgically.
Yes.
So they override. If you divide it, that's what he wants to ask. That if more than 50% of the aorta is arising from the RV and pulmonary arteries arising from the RV, it goes into the diagnosis of a double.
From the picture, it appears that the transducer was a bit rotated to the RV outflow view, not the classical parasternal long axis.
Yeah.
Yes.
So that might have caused this erroneous situation.
Okay, show the other pictures.
So there's aortic regurgitation?
Yes.
How much?
It is mild, sir.
Did you get a murmur for that?
Sir, I haven't appreciated it, sir.
Okay, you couldn't. Fine, you may not get it. Could you show the descending thoracic aorta in that last picture you have shown?
Yes.
Yeah, where is the descending thoracic aorta? Keep it moving, keep it moving.
So this one, sir.
So from the appearance of the descending thoracic aorta also, it doesn't appear to be classical long axis view. Go to the other things.
There is a apical 5-chamber view, sir. There is a subaortic VSD is prominent over there, sir. It is overriding is approximately 50%.
So you have to say it is a non-restrictive.
Yes.
Liberal flow is there. Right to left or left to right?
Sir, there is bidirectional, sir.
Bidirectional.
Go ahead.
How many valve cusps in the aorta? It is tricuspid, bicuspid, any other?
Sir, it was tricuspid, sir.
RV outflow, how do you see it? And what is your comment about the RV outflow?
Sir, there is no RVOT gradient is present in this patient, sir.
No, that's not the question. Anatomically, how does it position? How is it looking?
Could you get any continuity between the RVOT and the pulmonary artery?
Flow is there or not?
Any flow?
No, sir.
Say that needs to be said. That is the most important issue.
So there is no flow from the RVOT to the.
What about the pulmonary arteries?
Sir, pulmonary artery is atretic, sir.
Pulmonary arteries are atretic or valve is atretic?
Sir, valve, sir.
So what about
Can you see the confluence? Can you see the confluence?
Yes, sir.
Without the pulmonary arteries being present, how can they do a palliative shunt?
Yes.
Okay, carry on. Quick.
So it is very unlikely that with this degree of atresia, you couldn't get any murmur anywhere.
You have to listen very carefully for collateral murmurs. You have to be very, because if you don't look carefully, you might miss it.
And maybe you have to breath holding. We usually ask not to hold the breath. Normally, breath But in these conditions, as Professor Narayan is saying, while you are being careful, you can ask the patient to breath hold in expiration. In this collateral, long, continuous, muffled collateral murmur.
Yes.
Any other things you want to show?
Sir, the arch, sir. It is left-sided aortic arch.
Left-sided?
Sorry, sir. Right-sided aortic.
Yeah.
Can you see the RPA, LPA from the suprasternal view?
So would you like to do a cath in this patient?
Sir.
Suppose she does not agree to any kind of, open heart surgery or things like this. What do you do? Can cardiac catheter and subsequent procedures help?
Bipul, answer Sar's question and then answer me another question. In this degree of pulmonary atresia, valvular atresia, why did you get this cyanotic spells? Okay, answer Sar's question first.
No, let's go to this spell first and then to the management.
Sir,
why did you get the history of spell? How do you explain that?
Sir, because of the immature respiratory center is there, sir.
So what are the normal mechanisms of cyanotic spell in a classical TOF?
Sir, because of the immature respiratory center,
that is one.
Sir, other is if there is a tachyarrhythmia, that may cause
tachyarrhythmia usually happens in the morning while straining at stool. That can happen while the baby cries.
In this patient.
But yes, any other mechanism?
Sir, infundibulous spasm is maybe a contributory part.
So in this child, when she was a child, what did it happen?
Sir, it is relative. As there is no RVOT gradient, so probably the spasm part is little.
Little or absent?
Absent.
It was absent. Okay, now you answer the other question. Should you do a cardiac cath here?
And if you are going to do a cardiac cath, what is your idea of doing it? Why are you going to do a cardiac cath? What will be the final management plan?
Bipul, quick.
I don't know, sir.
Don't know? Do you want to look into the collaterals?
Yes, sir. MAPCA.
You want to look at the shunt?
Yeah, first is a shunt.
Look for collaterals. If the shunt is flowing, but it is restrictive, can do something.
Yes.
Kajol. So what will be the management? Do you want to continue with the medical management or want to do, relief to some patient?
Sir, we should go for the relief, sir.
What kind of relief are you going to give? Another
sir, as the RV function is preserved.
Yes, what can you do?
Sir, RVOT reconstruction can be done, sir.
How?
Sir, by the
how the main pulmonary artery, confluence is size. It is quite good size.
No, sir, it is not a good size.
So, do you want to go for other kind of imaging?
Yes, sir.
Non-invasive? Sir was looking
CT pulmonary angio, sir, should be.
Pulmonary angio or CT of the whole? Not only pulmonary angio, have a look into the other things also. CT angio of the heart. Yeah. So you have to look into the confidence size. Confidence is preserved. Dr. Guha has already given a hint that shunt surgery was done, so it must be present. But if you want to give relief to the patient, you have to know about the branch pulmonary arteries, how they are sized. Just reconstituting the RVOT, as you said. And that is more difficult. It is better to give a valve conduit.
Yes, sir.
From RV to PA, give a valve conduit, but that has to have a good size. And as the lady is surviving to till this age, must be there are good collaterals. So it is a detailed assessment by different imaging techniques, by catheter, as Dr. Narayan was suggesting, then a discussion between the patient, the relative, then the surgeon, anesthetist. That means the whole heart team has to be there before taking a decision. It's not a straightaway classical top repair. So you didn't give this possibility, or did you give this? I don't remember, in the diagnosis differential.
Which one, sir?
This is a PAVSD.
Yes, sir.
Pulmonary atresia VSD.
Pulmonary atresia he didn't mention.
Yes, sir.
So that is, here you have to bring another possibility. This is known as PAVSD, pulmonary atresia VSD.
Yeah.
What are the 4 types of tetralogies? You have tetralogy which is classical with severe PS. You have tetralogy with severe pulmonary atresia. You have tetralogy with absent pulmonary valve, and you have tetralogy of the AV canal type. So this falls in the second category, VSD with pulmonary atresia.
I think we should call it a day. We are already pretty late.
Yeah, I think.
Thank you. Thank you, everybody.
Thank you for this presentation also.
For wonderful presentation and participating in this discussion. I thank
you,
everybody.
Shantanu.
And
personally, Shantanu, can you hear me?
Yeah.
I'm personally thank you, because while in the flight I forgot this timing, etc. So personally, I thank you for calling me.
No, just I go on reminding people. Don't worry. So next month we'll again have another session of this type, and we will perhaps do the hemodynamics or an oximetric data analysis, which we couldn't do today.
And I have a brief review from the DM students, whether they were benefited with this session or not. 3 sessions we had.
Yeah, at least for me, it was a good revision, and learned some important points from Dr. Harikrishnan. So I think he must, continue with the second half.
Yeah, we'll continue, definitely. We'll definitely continue with this thing and request him to continue. Now,
do you still catheterize these patients, these congenital heart disease patients in your hospital, Dr. Shantanu?
I am no longer in the...
Yeah, I know that, but were you doing that?
Rarely. Some cases we used to do for academic purpose, to be very honest, because most of the information and the whatever surgery is being done at our centers, the most of the informations we get from the echo. Sometimes for the coronaries and all, we sometimes used to do the...
Nowadays, CT angios are so good.
I think.
With the CT angio becoming widely available, that requirement is also dwindling.
Because actually, while trying to do all this difficult catheterization, often sinuses becomes deepened in this.
Yeah, and you lose patients also, especially the very small ones. Yes. So unless you have a good surgical outlet, There is no point in risking a catheter in these patients. But yes, I agree that CT angio and MRI is taking a good load off from
it. It has just literally overtaken the cardiac cath in these particular patients, excepting, of course, we don't get the hemodynamics, but we can interpret it and get the hemodynamics from the echo. So almost all the information, what is required, we get it.
Only the thing that is not get the PF pressure, but that is not required in this PF
pressure. It is in this particular scenario, it is not that required. Okay then, with thanks to everybody.
Thank you. Good night. Good night, everyone.
For it a day. Good night.
Good night. Thank you
very much. Next month, and we'll intimate you well in advance. Thank you very much.
Thank you.